welcome, and thank you for joining us for DocToks with Dr. Forrest Tennant and friends. I would like to let you know that in 5 days from now, DocToks celebrates our 2-year birthday. So happy 2-year birthday to DocToks. I can't believe it's been 2 years, but it has. And happy birthday. Thanks for being such a good family. Dr. Tennant, it's all yours. Take it away.
Good. Thank you very much, Jamie. Yeah, the 2 years has gone fast, and there's been a lot of changes actually in 2 years. Just before you turned on the mics, you started mentioning about how all of us who not only watch this podcast, but who have the diseases that we target need to support each other and are really a family. Now, I want to emphasize that because you kind of took the words right out of my mouth. The new book on Epstein-Barr virus has caused a lot of great interest and has brought home another point that I want to emphasize. There are millions of people with chronic pain. There are lots of diseases out there. But when somebody develops something like adhesive arachnoiditis or true RSD or some of the autoimmune diseases that we have, and now with Epstein-Barr autoimmunity coming forward, it's very important for everybody watching this to understand that we're a rare group. We are a small group. Now, here is what I'm getting at. We who deal with severe pain, intractable pain, palliative care, end-of-life issues, that's all we talk to. And so you can kind of get the idea that we're some huge group. We are not. The medical field, the medical profession, the government, the insurance plans, they look at healthcare in the major diseases. Okay, things like diabetes, arthritis, asthma, peptic ulcers, hypertension, cardiac failure, these kind of issues. And there are millions and millions of people with those diseases, and compared to them, we're just a little small group. Now, what does that mean? Well, first off, it means that we have to stick together. Okay, that's number one. Number two, it means that you're going to encounter an awfully lot of people in the medical field who don't want to see you. They don't want to talk to you. They're not interested in your disease. They're overwhelmed, taking care of, arthritic knees or hypertension or something. And so I've got a lot of correspondence here recently in which I think the patient or the individual who had the intractable pain or the disease misjudged how to communicate to the medical profession. And I'm going to ask Mark to weigh in on this a little later in the program. But what I'm getting at, now that we're actually bringing the Epstein-Barr forward, a lot of physicians are getting very interested in that because they feel they've got something they can treat, they can get their hands on. And so that is a good thing. But the thing I have run into, and the question I can't answer for you, is just how common is Epstein-Barr autoimmunity? Now, the Epstein-Barr virus is in everyone. I mean, it's a normal parasite. And it lives in the throat membranes or it lives in your lymphocytes. But I do not know how common it is. All I know is that practically everybody watching this show and everybody I deal with has it. Now, if you read the medical literature as recently as the 2024 current diagnosis and therapy, they claim that reactivation of the Epstein-Barr virus is a rare occurrence and only occurs in people with immunocompromised systems. Well, they may be right, but I do know that all our people have Epstein-Barr autoimmunity. So I want people to realize this. If you go to a pain clinic and you tell the pain doctor, well, I've got adhesive arachnoiditis, or I've got Ehlers-Danlos syndrome, or I've got Marfan syndrome, or I've got Epstein-Barr autoimmunity, they're going to say, see the door? Don't let it hit you on the way out, because they're not interested. They are there to treat you symptomatically. They're not there to treat your disease. And we're going to talk about that in a little while. You've got to remember that when it comes to dealing with pain issues, you have two levels. You have treating a thing symptomatically. Now, you got to have symptomatic pain treatment to function. And so that's really step one. And it's very important. And you're going to, and everybody associated with this program is an advocate and thinks we should have a few changes of not only laws and regulations, but attitudes involving opioids and pain. But that's on one level. On a second level, you want to treat the cause of the pain, the underlying cause of the pain. Now, the pain clinics of the United States are not here to treat the cause of your pain. So if you go there and tell them that you've got adhesive arachnoiditis, you've got RSD, or you've got Ehlers-Danlos syndrome, they don't want to hear it. They're not trained to treat it. That's not what they were set up to do. And in a little while, I'm going to ask Dr. Ibsen to weigh in on this as well as myself. You want to say something right now, Mark, real quick on that? But pain clinics in this country were not established to treat your pain, or to treat your pain symptoms, not the cause. Okay, what does that mean?
There's no payback for curing anything in the current system.
That's very well said. Yeah. Well, that's why we're going to talk about curing your problems right now. Okay. We're going to have a lesson now on something that comes up several times a day, particularly since we sent out our bulletins and our book on the Epstein-Barr autoimmunity. We're going to teach you how to read the test. Okay. And we're going to teach you what to tell your doctor and for you to know a little bit more about Epstein-Barr autoimmunity. It's critical that you do so. Now, to get started, to be evaluated for Epstein-Barr autoimmunity, you have to have 3 blood tests. Okay, now there's about 8 tests available, but they're not for autoimmunity purposes. You have 3 tests in the panel. You have one that's abbreviated VCA. Just write VCA because everybody knows what that is now. That stands for viral capsule antibody or capsid antibody, VCA. Okay, now you have a second antibody called Epstein-Barr nuclear antigen antibody, and that's abbreviated EBNA. VCA and EBNA. Okay. Now, there's a third test, but let's talk about what these two mean. These are antibodies, and they're protective antibodies, meaning that whenever you get it, if you got mononucleosis or you have reactivation of that virus, your body's going to make an antibody. Okay? One of them is a VCA, and one of them is an EBNA. In other words, it makes an antibody to 2 parts of the virus, its capsule and its nucleus. Okay, now those antibodies are made, and they're going to be in your body forever. Okay, they're not going to go down. They're there because the body is trying to give you a protection. And it's an antibody, just like you have an antibody to chickenpox or an antibody to COVID or an antibody to chickenpox or anything else. It's an antibody made to help the body fight the virus. Okay, so those go up, and that's what that means. Okay, now there's a third test that's extremely critical for anybody with chronic pain. Now, who should be tested by these 3 things? I'm going to give you my simple formula. Anybody who has chronic pain over 90 days and has got to take medication each day to relieve it should be tested for Epstein-Barr autoimmunity. Okay? I know that doesn't sit well with maybe some people, because you're talking about a lot of people. But from what our studies show, it's warranted. Okay? In other words, what it's starting to show is that the Epstein-Barr virus starts off its whole cycle by first giving you fibromyalgia, and then migraine, then irritable bowel, then carpal tunnel, then small fiber neuropathy, pudendal neuropathies, and then it gives you a slip disc, and then it gives you, some kind of neuropathy like a sciatica, And then in the end, you might get adhesive arachnoiditis if you don't have something stopping the process along the way. So now we're starting to understand that this Epstein-Barr viral autoimmunity starts in a whole chain of painful events. And so if you, anywhere along that line, you have such pain, you've got to start taking gabapentin every day or some NSAIDs every day, opioids every day. If you are down to where you're using medicine every day for a pain, my recommendation is you have this 3-panel test. Okay. Now, I'm going to talk about the third test in a minute. We now have a fairly recent test called the early EBNA. The key word is early. Okay. Early. Now, I'm also going to digress here for just 1 minute. I want everybody out here watching this to write these down, take them to your doctor. Okay? And you should learn how to interpret the tests. They're not hard. And it's just like a diabetic. A diabetic's got to know what their blood sugar is. Somebody with high cholesterol's got to know what their cholesterol means. Somebody with liver disease has got to know what their liver function needs. If you've got chronic pain, you need to know what your Epstein-Barr antibodies are. Okay? And again, it's new, but it's not hard to learn. Okay, you only got 3 of them to learn. Now let's go back and just say what these are for and what the treatment is. Okay? Because a lot of the treatments you can do on your own, some you may need doctor's help on. Okay? Okay. VCA is an antibody, and most of your big labs now, both Quest and LabCorp, they have a cutoff of about 21 or so. Now, and we see a lot of people who have severe chronic pain have antibodies so high the lab can't test it. So it's going to come back above 500 or above 600. In other words, the lab can't even test that high. Now, what does that mean? That means that you are a chronic reactivator. It's like somebody who reactivates their herpes or their shingles. That means that you periodically reactivate the Epstein-Barr virus. And that's how you'll get your antibody levels driven up to 200, 300, 500, 600. In other words, several times normal. That means that during times of stress, you reactivate your virus, then you put the virus to bed later, but then you have it come back. All right? That's what that means. Okay, now let's go to EBNA, the Epstein-Barr nuclear antigen, the nucleus antibody. Now, if that's high, that's bad. Okay, it means you not only reactivate the virus a lot, but it is that antibody that has a component called an autoantibody. An autoantibody. Now, I've talked this before on what is an autoantibody. If you have chronic pain over 90 days and you got to take medicine for it, the word autoantibody needs to become as familiar with in your vocabulary as does the word breakfast cereal. You've got to know what that means. An autoantibody is a protein or a globulin protein that somehow has decided that your own tissue is an enemy. And so it starts eating away at it. It attacks it. It attaches to your tissues and it starts eating away like rust. Rust is the right term. It starts rusting your tissues. Now, it likes to rust nice, soft, juicy tissues, those with a lot of collagen in it, things like fascia and cartilage, small nerve fibers, the arachnoid membrane, opioid receptor sites, things like this. It likes to get the juicy stuff. Why would you want to take on a bone when you can eat a small nerve? And that's what autoantibodies do. You almost have to think of them as being like Pac-Man. They're alive. They move through the bloodstream. They attack the nice soft tissues that give you pain if you can't restore them. So that's what an autoantibody is, okay? Now, and then you have the early antibody, and that means that you have active reactivation. Now, we see really in all the patients that we've tested, whether they've got fibromyalgia and irritable bowel, or whether they've gone all the way down to arachnoiditis, or just down to multiple slip discs, or cervical arachnoiditis or something, the most common pattern we see is somebody who has, frankly, maybe all three positive. Okay. Sometimes it's just two of the three. Okay, but now let's cover treatment and what they mean. Now, I know this is a little complex, but that's why we're going to have this session and maybe some more, because in my opinion, everybody with severe chronic pain over 90 days that you've got to take medication for, this has got to be, in my opinion, part of your new treatment, part of your treatment. Okay, if you have a high VCA, now practically everybody is going to have this. The high VCA means you reactivate the virus periodically. So what do you do? Now here's something we have some solid information about. There are some simple measures that appear to stop future reactivations. Okay? Now they're in the textbook, and there's been some laboratories that have tested a lot of compounds, a lot of medicinals, to find out what stops the virus from reactivating. Now the old famous one is vitamin C, okay? And the old mineral zinc is in there. Selenium seems to be in there. And there are a number of other medicinals. They're in the textbook, and I'm going to read them off to you. Resveratrol, luteolin, astragalus, curcumin, andrographis, selenium, zinc, and lysine. Okay? Now, I'm going to give you my favorites. Now, there's a lot of doctors have some other favorites, and they may be better than my favorite. I don't really know, because they seem to work. And so the one thing that works in this business is to stop the virus from activating in the future. You can't do much about the past, but you can stop the future. And so my favorite that I like is vitamin C, 3,000 to 4,000 milligrams a day. 1,000 to 2,000 milligrams in the morning, 1,000 to 2,000 milligrams at bedtime. And then the mineral I like the most is selenium. Some people like zinc better, or boron. I like selenium with 100 to 200 milligrams a day. And then I also like, I'm not sure exactly what it does, but the third favorite Epstein-Barr treatment for me is monolaurin. It's a derivative of coconut oil, and we're not quite sure how it works, whether it inhibits the activation or whether it kills the virus maybe. But monolaurin has become the most popular anti-EBV drug there is, okay? Throughout the United States, it's become the popular drug, okay? Cheap, you get it over the internet. Another one of my favorites is the combination of what they call PEA and luteolin. Trade name is Marica. That's another one of my favorites. But there are some others. There's a lot of innovative people have made one. Here's one called EBH6. It's really a homeopathic formula. Some people like that. Quercetin, a lot of people like that now. And here's one that we actually, it's made by a mid-level marketing company called Modern America. And it's got selenium, vitamin A, vitamin C. It's a good one. So I don't really care where you get them, whatever your pocketbook can afford, and then find one that you like good. But I will say this. When I hear today, didn't used to, but today when somebody says they've got arachnoiditis or they've got EDS, you know what my first recommendation is? Vitamin C, 2,000 milligrams in the morning and 2,000 milligrams at night. It's cheap, simple, never hurt anybody. And I never used to be such a believer in vitamin C, but I am now. And so vitamin C and selenium is the first things I tell people to do. Is it the best? I'm not certain it is. Dr. Imps may have a little different opinion. That's fine. But everybody should take these tests. If you've got a high VCA and a high EBNA, take these prohibitive drugs. They prohibit the reactivation in the future. Okay? Now let me go on to what the EBNA antibody means and what autoantibodies mean. All of you who've watched this program over the past 2 years have heard a lot of talk about collagen. You've heard a lot of talk about peptides. You've heard a lot of talk about ketorolac and about methylprednisolone. We didn't know this. We just thought that we were working on the regrowth or the regeneration of nerves inside the spinal canal. Turns out that's only part of it. Autoimmunity is unfortunate in that we don't know how to get rid of it. In other words, it's like rheumatoid arthritis and lupus. In fact, it may be the same autoantibodies. We can control it, we can't cure it. So, if you've ever had these high autoantibodies, you are now burdened. I hate to bring bad news, but you are now burdened with keeping that rust from ruining you and causing you continuous deterioration. Okay. Our studies are starting to show is that those people who have high Epstein-Barr autoantibodies don't do well unless they're taking ketorolac has been dynamite. Methylprednisolone, even prednisone, on low dosages over intermittently. And so also this is where our peptides come in and our collagen substitutes and some hormones, which I may talk briefly about in a few minutes. The bottom line is the thing we've been preaching and teaching here for a couple of years, we've now learned that they have the mission of fighting autoantibodies, not just plain inflammation. And so, again, we're going to come back and on this program, BP 157, thymosin, KPV, these are dynamite, and we want people using these peptides. We want people on collagen supplements, and we certainly want people, the people who have done best with adhesive arachnoiditis in our studies of those who have taken periodic dosages of ketorolac and methylprednisolone. And when I say periodic, it may be once a week, maybe twice a month, but they're doing it. And we now know that one of the things that they're doing is controlling the autoimmunity of the Epstein-Barr virus. So anyway, that's where that stands. Now let's go on to the one that physicians are going to have to get involved with. And that is people who have elevated early EBNA. That means the virus is active. Okay? It's active as you sit there. It means it's producing more autoantibiotics, more pain, more disability, getting you closer to being bedbound, closer to the grave. It's not good. Okay? But you want to know about it, and I'll tell you why. That's the one thing we can reverse. But now the studies are early, but if you have an activated Epstein-Barr virus, you're going to need your doctor's help. The doctor's going to need to put you on antivirals. Ivermectin is dynamite. That's got a great place. Ivermectin is on it. And so the two things that we are recommending there, if you do have activated virus, this is where I'm certainly recommending therapeutic trials of, acyclovir, valacyclovir, that's Valtrex, famciclovir, that's Famvir. The doctors know about these, and they've used them because they've used it for herpes zoster or shingles, or for recurrent herpes genitalia or of the lips. And so all the doctors know about antiviral therapy, and they're pretty good at it. And they may have one antiviral, they prefer that over another. Some of the infectious disease specialists are really loading up on these antivirals, giving 2 or 3 of them. They're really going after it. Is that the way to do it? I don't know. I'm not going to say it isn't. Maybe that is. So right now we're in this stage to where everybody knows we got to do something. And we know that antivirals, we know that corticosteroids, and we know that ivermectin, these things are all having some place with it. The goal of treatment is to reverse the activated virus to inactive. And we do have cases now in which people are converting from active early EBNA to negative, okay? And so that's where we're at today. I know this sounds a little complicated, but just write on a piece of paper those three antibodies and a few notes on what you do with each one, and it'll come to you naturally on what we should do. Now, those are the three. If your doctor wants to order the blood test, those are the three you want. If you want to order something else, that's fine too. But these are the ones you need, okay? Because you're looking for autoimmunity. You're not testing for infectious mononucleosis or post-transplant infectious mononucleosis. You're looking for Epstein-Barr autoimmunity because that's what's giving us the intractable pain. That's what's given, they're invading the people who have ankylosing spondylitis or EDS. These are the bane of the people who have these kind of genetic problems and who under stretch activate the Epstein-Barr virus. So again, we know that the people that Mark and I deal with all the time have this. I don't know how many people out there in the real world do, but among our people, it's very big. Now, I'm only going to take 5 minutes here quickly to introduce you to the next subject, but it ties together, and we haven't talked a whole lot about it. But I'm going to introduce you to something that we've mentioned on this program, but not a lot, and that is hormonal therapies for severe chronic pain and intractable pain. Okay. Now, when you mention hormonal therapies, doctors, patients, the media, everybody sort of says, "Oh my God," they jolt backwards and they say, "Oh my God, hormones! I can't take hormones. I don't like hormones. I don't know what this is all about," and it's kind of a natural reaction because it has a lot of pejorative thoughts to it. The first thing I want you to know about hormones is that it's a new field in medicine. Okay? It's a new field in medicine. Do you know that the word hormone never appeared in a medical dictionary until 1906? Hippocrates never used the term hormone. Okay? Dr. Edison never used the word hormone, and he invented Addison's disease. In other words, the word hormone and the specialty of endocrinology is less than 100 years old. Now, in medical terms, that's nothing, okay? And so it's new and it's very controversial, very poorly understood, very poorly understood. I just want to walk you through a few things about it, and then we're going to have to cover it because, again, if you have severe intractable pain, you're going to have to use some hormonal therapies, and you probably do now, and you don't realize that's what you're doing. Okay? Probably don't know. Okay. There's about 4 basic reasons on why hormones are used. Okay? 4 of them. Now, the first one is replacement. Okay? Now, replacement really brought hormones into sort of existence back 100 years ago. And the first thing that doctors noticed was people who had big goiters, and then they went into dry skin and low blood pressure and slow mentation, gained weight, and they found out that it was thyroid. And then the second thing they found out was that you started losing weight and you started getting infections and skin problems, and that was called diabetes. That was a lack of insulin. Okay. And so the first uses of hormones therapeutically were thyroid and insulin. Now, the third one that came along was cortisone. And Dr. Addison might surprise you. He didn't actually invent the word cortisone. He just said your adrenal glands were shot. Okay. He never mentioned the word hormone. He never mentioned the word cortisone. Or anything else. He just knew that your adrenal glands went south. So that's what he did. But anyway, in the 1920s and 1930s, Addison's disease got recognized as a clinical entity by doctors, and there were a couple of famous ones who managed to take extracts out of the adrenal glands, and they even made it pellets and plant them under your skin. John F. Kennedy was one of those people, incidentally. where they actually implanted his tablets under the skin. Then, as time went on in the 1940s, they found out that cortisone and pregnenolone from the adrenal gland cut down inflammation. And pregnenolone was the treatment for rheumatoid arthritis up until 1950 when prednisone was discovered. And so as we've had an autoimmune and an inflammatory process. Going on into the 50s and 60s, hormones became famous because they modified the menstrual cycle. And that allowed birth control as well as some other gynecologic problems. And so a lot of people, when you mention the word hormones, they think in terms of only estrogen or progesterone or something to do with the menstrual cycle. And that's one use, no question about it. And then, however, the new kid on the block that I want to introduce you to, and then we're going to move into our guest, and that is the use of hormones for tissue restoration. Okay, tissue restoration. The most famous part of that is the only people that have been doing that has been in the military, sports, and then I and a few other people have been using it to try to restore tissues in severe intractable pain. Okay, now, and one thing about it, endocrinology doesn't do this. Endocrinology is the study of the disease of the glands, but functional medicine doctors, some doctors who are interested in pain and others are starting to use, and we're going to talk a lot about it, the use of some hormones to restore tissues. And in my opinion, I'm going to cover it a lot. In my study of people who are deteriorating with adhesive arachnoiditis, their hormones are almost in arrears. Okay, and they're going to have to be tested. And one last thing before we move on. The thing that has brought hormones to the forefront have been tests. It might surprise you to know that getting hormone blood tests up until about 10 years ago was very difficult. In other words, we knew there was estrogen, we knew there was testosterone, we knew there was pregnenolone, but now they have panels for these, just like a panel for the Epstein-Barr virus. So laboratory technologies come forward here in this century to make the use of hormones have some new uses, and we're going to be talking about those because, in my opinion, they are essential in the treatment of intractable pain. So I'm going to shut off there. We have some fascinating guests tonight who have been with us before. I understand, Jamie, that you have Pat Irving back with us.
Yes, sir. We've got Pat and Monty.
And Monty's here too.
Yes, we're so happy to have you both with us. And if you could.
Perfect. Can you hear me now, Jamie?
Yes, we sure can. Welcome, Pat. Great to see you.
Oh, thank you so much. And do I have my partner on? Is Monty there?
I'm here, Pat. Monty. Oh, hi, Monty.
Yay, there's my
How you
partner.
doing?
Yay. Oh, it's wonderful to be here this evening. I am so grateful for this opportunity every time. And Dr. Tennant, before I go into my piece, I want to say these are brilliant lectures that you provide us. It is outstanding, the quality of the material that you give us and how pertinent it is to all of the situations that we find ourselves in. Just very briefly, my son has MECFS, which is chronic fatigue syndrome, like long COVID.
Yeah.
And his Epstein-Barr virus is through the roof. And I have been relaying the information you've been giving us to him. And he just wants to relay his gratitude to you.
Hey,
so
you're welcome. He has one of the diseases in the chain
yes.
of torment, I call it. Just one thing, this wasn't what I wanted to talk to you about, but maybe it is. One of the things that's happened in the United States, good or bad, it's just a fact, and that is universities have given up doing clinical research. And during COVID, the last vestige got wiped out. The universities use their physicians to bring in the money. They've got to support those places. And so all the research is given to basic science. Okay? And they're doing a great job. I mean, I read some great papers every day. I read a bunch of new papers on autoimmunity done by your basic scientists this morning. But what that's made is that those of us who are physicians, who are research trained, have had to go outside the university, set up our own foundations, our own money. I'm not the only one. I've got a handful of other doctors, and I've got one I may bring onto our own foundation and try to raise some money to do some research. So anyway, that's another subject. However, one of our buddies, Chris Ogden, and I are talking about we need to start some kind of a seminar or some public things to start disseminating some of this. But so anyway, my old universities, they don't do much clinical research anymore. So we had to go into another way to do it. But we'll get it done one way or another. Yeah. So anyway, Pat and Monty, I guess first off, you guys have been so active and so helpful and in opening up avenues of communication, if you will, with some of the very right people, particularly in California. Could you and Monty give us just a little idea about what you've been doing? And then I've got some special things I'd like to ask you, and I know Mark will. So give us a report, is what I'm saying.
Absolutely. Just briefly, before we jump into the California boards, the pharmacy board and the medical board, I do want to let people know there was some really good news yesterday, some wonderful happening. Dr. Lawhern spoke to the National Institute for Drug Abuse, specifically to the lead physician in chief there, and he was able to convey to her all of the situation that we're facing with chronic pain patients essentially being discriminated and shortages and all of the trauma that we're facing. She was very attentive. You know, the mission of that group is very limited. Of course, they primarily do look at addiction medicine, but they were very open to taking our message and giving it to other groups, including the National Institute for Neurological Disorders, which would be fantastic because their primary look right now, she said, is at pain and how pain interacts with other diseases. So we're very hopeful. I know we just hear bad news after bad news, but this was for us a really big breakthrough. And it sounds like more good things will happen from that. So
Well,
that
Dr.
was
Volko
really
is first class. I'm aware of who she is. Yeah, that's great to know. Yeah, that is good news.
yes.
Yeah.
Yes. And she was hoping to attend. She got pulled away, which we completely understand. It was her chief of staff who was there. And I think Holbein, Monty can jump in with the name. I think it was Holbein. But anyway, her chief of staff was there and very, very receptive. And with that, we will switch over to what's happening in California. And what I'd like to say is what Monty and I will talk about with California is really apropos to any of the work that you could do with your state pharmacy boards or medical boards. It's a slow process. We didn't do this quickly by sending one letter or one phone call. It's really been months and months of slowly listening in. What we've been doing is listening in to both the medical board and pharmacy board. And whenever we have an opportunity, boy, Monty and I are there being able to give public comment, much to our pleasure. Yes, Monty got a positive response, and the response was that the medical board, they wanted to set up a meeting with him, and he invited, yay, and he invited Red and Kristen and myself to sit in. We were able to have an hour-long conversation with Dr. Thorpe, who's a medical physician on the board, and then an executive director, an entire hour. It was wonderful. So, Monty, would you like to go into a little bit of detail maybe about the highlights of what we talked about?
It's an interesting story. It's one I really, one of the pleasant things of all the stuff we work on. But one person you didn't mention, and I'm going to, is Kristen Ogden.
Kristen.
our involvement, my involvement with the board started with watching and listening to Kristen Ogden speak to the medical board as they were updating their opioid prescribing guidelines. So I got involved in that process and participated quite a bit. I've routinely
Monty, can you speak up a little?
I've routinely provided written and spoken comments. And we've had a friend on the board for the whole time. His name is Dr. Thorpe, the gentleman that Pat just mentioned. But we've been beating them up, or collectively, politely, respectfully beating up the board about the fact that they haven't rolled out their 2023 opioid prescribing guidelines aggressively, like they were going to do. Webinars, going to other professional boards, meeting with doctors, actually doing possibly some CME training on their guidelines. And the other thing that has gotten the interest of Dr. Thorpe is the impact on pharmacy shelves of the AG's opioid settlement with the 3 major distributors. He's been interested in that. He spoke to the board about that. I piggybacked on his comments to the board. Long process, and we've developed a relationship. And I spoke to the board at their last meeting about virtually about their the impact of the injunction on the supply chain to the pharmacy shelves, and to the fact that they really need to get with the program and get their guidelines aggressively rolled out. And while that meeting was still going on afterwards, I got an email from the lady that coordinated it saying that both Dr. Thorpe and the executive director of the board, Mr. Reggie Varghese, wanted to have a meeting with me. And Pat told you about the meeting we had. It was great. It was an hour long. Red Lawhern participated in it. Kristen Ogden did, Pat and I. And I wanted really Red Lawhern to meet Dr. Thorpe. He's been a major supporter of pain patients in California. And I think we may have something going there. I followed up with an email back to those folks, to the 2 gentlemen, and got a reply from Dr. Thorpe with his personal email and his cell phone number, which I am not going to broadcast. But I think we're making some real progress there. And so I'll shut up now and turn it back over to you, Pat.
Great. So if any of you, I'm going to volunteer for, go ahead.
Can I make one last thought? The thing is, I'm trying to encourage people across the country to follow the process that Kristen Ogden, myself, and Pat have done with the Board of Pharmacy and the Medical Board of California. I don't think cold calling and writing them letters or emails is going to cut it. You have to establish a relationship, and the way to do that is by participating in their meetings respectfully. That's what I think is the key to our success, and I'm super excited about it.
Absolutely. And if any of you are interested not all boards are going to be this welcoming. Believe me, I understand if you try to call the board in Maine, they would probably hang the phone up on you. But it's worth a try. And if you, I'm going to offer myself. Monty can say what he wants, but if you need help, if you have questions, please let me know. And I know we would be happy to give you some suggestions if you're trying to get a hold of your medical board or your pharmacy board. So did you have a question, Dr. Tennant?
Yeah, you just gave me an opening on a question that I really want to ask. We have people who really should be, frankly, complaining to their medical boards. They're being mistreated. In some cases, the mistreatment has resulted in deaths. We had this week, I unfortunately am aware of a doctor who took somebody off benzodiazepines, cut them in half one day and another third another, and of course they led to suicide. Is there a way that you guys we would train people how to complain to a medical board? One of my frustrations throughout all of this has been, and Mark, I'd like for you to weigh in on this, people who are mistreated it is time that those people themselves not only complain to their medical boards, but the person paying their bill, that insurance company. 75% of physicians in this country now work as an employee for either a hospital or a health plan. And these people are getting by telling doctors not to treat them, ignore them, and we've got to have, and you guys have been, and if I say so myself, you guys are educated, you're experienced, you're knowledgeable, you're worldly, and the average person that I deal with are just ordinary people. They've never dealt with a government agency, and to think in contacting United Health and writing their CEO is just nothing they would even think of. Suppose we could have some kind of a training program for this?
I will say yes. I think there's certain things that you can lay out in your complaint that will help it to be more understood. It is really intimidating. I mean, and the other thing is patients, when they complain, they're hurting and they don't feel good, and it's very difficult
Yes.
for them to come up with it. So, there may be, let me noodle on it, and there may be a way I can come up with a template of kind of things that you would want to present. Now, it will be different state to state, very different. We are very fortunate in California. The medical board in 2023 has the guidelines that they put out, which are really relatively pro-patient. And so what you would do is, if you have guidelines in your state, you can refer to them in your complaint. For instance, we're fortunate enough in the California board that says, in guidelines, it says that forced tapers are discouraged. You should be able to pause the tapers. It goes through all of the things that really would be protective to patients. Now, the board can't tell an entire hospital system, like they can't tell Kaiser, stop forced tapering patients, but they can address, like you're alluding to, Dr. Tennant, an individual patient that's had problems. Let's say they've forced tapered and it has severe outcome from them. They absolutely should use the guidelines from their state, write their board, and put in their complaint. I would very much encourage that. And if it's pharmacy related, let's say Dr. Ibsen has more cases than I care to even think about. If the pharmacist has refused them to fill a prescription, they can also write to the Board of Pharmacy, which would be a similar process, but a different board. Each board has a website. So if somebody just asked where in California the board is, it is in Sacramento, but you reach these boards essentially virtually on their websites. So Monty and I did not go in person. It's all, you find their website. First of all, you go to their website, find out, when their meetings, they'll have when their meetings are, who's on the board. And then if there are guidelines for your state, they'll have the guidelines there. So then you can read through the guidelines and use those to help protect you as you write up your complaint. Oh, absolutely. Monty, do you have thoughts on that, on using the guidelines as your basis for your complaint?
Most states, in my opinion, to my knowledge, are not as, even though they're not over the top, patient friendly. California is one of the better states.
That's true.
Okay, so I fear that the guidelines are going to hurt more than help in many states in the country. I hate to be a wet blanket, but I do think, the process, and I want to reiterate this. Kristen Ogden has made a couple comments in the chat, and she's nailed it right on. The way to get to these folks is to participate in their meetings. Now,
and just keep showing up.
Exactly.
Yes.
And that's a separate issue a little bit than if you have something happen with a doctor at a doctor's office and you're filing a complaint with the medical board. In California, that's a pretty straightforward process. It's all automated. I think they call it the Breeze system or something. But those kind of things are relatively simple. Pat I know for a fact, Pat has nurtured some folks here in California through that process. I have never had to file a complaint with the board. My interaction with the board has been more on a proactive basis, trying to get them to implement some change in their policies that will help the patients in California. One of the things I didn't mention earlier, the Board of Pharmacy is going to actually have a presentation by a couple of the distributors on the 16th of this month on the impact of the nationwide opioid settlement on them. And that's going to be at the Board of Pharmacy. I happen to know through the back door, one of the guys from the medical board is going to view that, just like I'm going to view it virtually from my office here in Southern California.
So Monty, Dr. Ibsen just underlined your statement. He writes, boards have doctors intimidated, and absolutely, I need to be careful that there are boards that are equally corrupt and have had the Kool-Aid. So you got to try your own board and see what they're like. If you can get one that's anti-pain patient, and then it's very difficult, but don't give up. Don't give up.
Litigate.
Thank you. Yes.
You can try it.
Mark, are you out there?
Yeah, I'm here.
Yeah, go ahead. What do you have to ask these fine folks or add to what they're saying?
Well, I must tell you that at least 3 times a day, I encounter a pain refugee or a patient who's seeking help, and I advocate with them, and it's all pro bono stuff. And I recommend to anybody who's been cut off from their medicines or forced tapered, or they can't get something from their pharmacy, that they file complaints. It is ad nauseum, these recommendations. I don't know how many people have actually done it, but it is so bloody simple to file a complaint against a physician who's given you bad information or cut you off unfairly, etc. And patient complaints have much more influence over boards than doctors complaining. Doctors just want to be invisible. It's basically, don't put the ring on your finger or Sauron will see you. So the doctors must, it's sort of like remaining invisible at all costs. So doctors do not want to be known by their medical boards because once they have you in their sights, you become their next target. And they don't give up. They don't stop targeting you, even if you beat them with a stick. So in fact, if you beat them, then they hate you. This is my personal experience, but so we need patients to be active with the medical boards, and there's no statute of limitation on unprofessional activity. If you've been treated poorly by a doctor or a pharmacist, that doesn't age out in 7 years or 3 years or anything like that. You can go back and you can say, I was treated poorly by this physician at this time, and I'm letting you know now because I'm no longer intimidated by that doctor, something like that. So I think patient complaints are a great way, but I got to tell you that the advocates that are in this room together deserve the Nobel Peace Prize for sitting through endless meetings with people pontificating about and completely ignorantly doing it, and that you have the patience to endure and create relationships. I really admire you. I'm going to remain in the rebel category because I'm already tainted. But I think that the more of us that can actually create relationships with the boards and ask nicely, then, and if it works, then great. And if it doesn't, I think publicity is going to be the next thing. It's going to be basically, we have to let everybody know that the board of, like my attitude would be, where's the Board of California in terms of promoting their guidelines? And if they haven't done it, then we'll do it. And proceed in that way. And that may not create the greatest relationships, but frankly, our relationships are adversarial with most of these people, and I agree that being professional and being appropriate in a meeting and not cursing and swearing and putting them down is probably a good idea. That's why I haven't been attending. But but I think that at some point they're going to need some public shaming.
Yeah. Let me, I just, an experience I had just in the last few days was with a prominent, I hate to, Monty and Pat, I want you to hear this, with a physician here in California. He's very well known, been president of his county medical association, on the board of one of the best hospitals, published a lot of papers, somebody I consult with quite often. And I asked him, I said, you know, what have you ever, he has the same philosophy we do. And I said, have you ever complained to the medical board as you're concerned about some of the doctors who are cutting people off drugs and causing all this havoc? And I think he summarized it very well. He said, Forrest, let me tell you, he says, you know this as well as I know, if I'm for it, the board's going to be against it. And so the word adversarial relationship, the reason why a lot of us can't get involved with you lay folks is if we're involved with you, you're going to go nowhere. They hate us. You know, 30, 40 years ago, physicians were thought and were the most respected people in society. Today, we have been denigrated. We've been pejorativized. We've been investigated, condemned. We are at the bottom of the public's totem pole. And so if you folks who are non-physicians don't advocate for doctors, that's why I'm so glad you're doing this. We can't help you. If we raise our hand, we'll hurt your efforts. They hate doctors. I don't know where this came from, but you got to remember that people on medical boards are political appointees. They're appointed by partisan political people. And so whatever view those partisan political people have is what your medical board is going to reflect. And so doctors today, you're right, they're hiding out. They're not about to raise their hand, write a letter, complain. Just leave me alone. I don't want to be known. Now that now the public might find this hard to believe, but the doctors fundamentally, as a group, there's exceptions obviously, but I think as a group, what you're going to find among practicing physicians is that they feel they're the enemy of the medical boards, and that they are there to be horsewhipped and denigrated and cast about by any variety of means. So that's why you've got, what, a third of the doctors are going to try to retire now and are bailing out of medicine. I mean, they're not going to stay with it. I think it's terrible for the country. When you start having a very negative opinion of your doctors, remember, we're all going to face one. Okay, you're not going to get around them, okay, because they're here, and it is tragic that we cannot help you get pain medicines that we need. Okay, so with that, with a sad note, all I can do is say thanks to Kristen, Monty, Pat, and all the rest of you who are trying to help out, because if you don't do it for the doctors, at this point, we're helpless. Okay?
Before you go, Dr. Tennant, you said earlier about how we don't know how many patients in chronic pain or how extensive the Epstein-Barr reactivation phenomenon is. I'm suspecting, and I think you do too, that it's bigger than we think, yes, and that we're dealing with an iceberg kind of phenomenon here. So what I want to say to the people who, you mentioned this great quote about we are uncertain about autoimmunity and its effect on things. And my response to that is, we don't know yet. I think this may revolutionize the practice of medicine, and particularly what I think it may revolutionize is that every patient that we see that confuses us, that we want to blame the patient because they're not getting better, they got Epstein-Barr virus reactivation.
That's, well, I'll close it out. You're absolutely right. And I went over a lot of records just this week, and they not only may have the Epstein-Barr virus, they may have titers that are way, way above normal on 2 or 3 others at the same time. In fact, it looks a little ominous to me. So let's close out with a word of thanks to Monty and Pat. Please help us. We need you. And secondly, that word
And
iceberg
thank you.
going to stick with you. Yeah, thanks so much. Thank
Nice.
you. Well, we'll carry on next week, and let's keep moving. Thanks so much, everybody.
God
Good night.
bless us,
Good
everyone.
night.
Yes.
Good night.
Yes. Thank you all.
Good night,
Thank you,
Jamie.
Dr.
Love
Tennant.
you guys.
Love
Love
all
Thank
of
you,
you.
Kristen.
Thank you, everyone. God bless everyone.
Night,
Every
night,
listener.
and thank you.
Strong.
People. God save the pain warriors.
Thank you.
Amen.
Right on, Carson. Thanks, Monty.
Yeah.
Thanks, Pat.
Much.
According to
Thank
my
you.
doctor, 80% of the world's population has the Epstein-Barr virus and don't even know they have it.
Mhm.
80% of the world's population.
Usually by 2 years old.
How do you get tested?
It's the early EBNA
It's the EBV nuclear antigen
and the VCA.
and the EBV VCA.
EBNA, early EBNA and VCA. Is that right?
Yep. Well,
Yes.
the fact is, we've all just got to buy the book.
Yep, that's it. Buy
Page
the book.
82.
Yeah.
Thank you.
What'd you say?
Page 82.
Oh, page 82. Yes, that's
Oh my
awesome.
God, we're going to quote it like scripture now. Now, thank God.
Let's quote it. Huh?
That'd be great. Yep, it'll
So
be great. Thank you all for joining us tonight. Thank you.
Love
Good
you
night.
all.
I love you all.
You too.
Back at you.